Hello, and we are so excited that you've joined us today. I'm your moderator, Faith Rogers with DKB Med. You're in for a great presentation today with our excellent faculty who do their best to make sense of all of this. For those of you that may be joining us for the first time, welcome. And if you've participated in some of our over 150 webcasts on this important topic, we do welcome you back. We've been developing COVID education since March of 2020. So 2 years later, we are incredibly grateful for the progress we've all made in managing patients during this pandemic. So here are those great faculty I mentioned earlier. For those of you who have been with us since last year, you might recognize them. And for our new learners, please meet Dr. Auwaerter and Dr. Klimpl. Thank you, both of you, for taking time out of your busy practices to be here today.
Delighted, Faith. Thanks for having me.
And here are our faculty's disclosures. This educational activity is supported by an independent educational grant from Gilead Sciences Incorporated. All activity content and materials have been developed solely by the planning committee members and faculty presenters. Please note that the material presented in this program is current as of April 6th of 2022. So if you're watching this or listening to this on demand, please do refer to the NIH and IDSA treatment guideline websites for the most contemporary information. The learning objective for today's program is to describe current management strategies and identify potential treatments for patients with COVID-19 requiring hospitalization. I will hand the presentation over to Dr. Klimpl. So Dr. Klimpl, thank you so much for your time.
Thanks, Faith. So first and foremost, we have been dealing with this pandemic together for over 2 years now. There have been several spikes, most recently the Omicron spike. And as we have dealt with COVID-19 together, more data has been coming out, and we have been changing our therapeutics, changing our diagnostics as we have learned more and more about this virus. The first thing that we're going to be talking about during this webinar is anticoagulation, though this entire webinar is geared towards hospitalized patients. So this is a summary slide of what we're going to be talking about in terms of anticoagulation therapy. The big takeaways from this is if you're a hospitalized patient and do not require supplemental oxygen, normal prophylactic doses of unfractionated or low molecular weight heparin are fine unless contraindicated. If you are a hospitalized patient who is on low flow oxygen and your D-dimer is above the upper limit of normal and you are non-pregnant and you have no increased bleeding risks, there is an indication for therapeutic anticoagulation. Now, this recommendation for therapeutic anticoagulation is not retained in people who are on high flow, non-invasive ventilation, invasive ventilation, or ECMO. For patients like that who are critically ill and unstable, they need to go back down from therapeutic to prophylactic anticoagulation. And we'll talk about the studies that drive that data right now. So the first study that I'd like to talk about is called the HEP-COVID trial. This was a smaller trial, 257 hospitalized patients, and they picked patients who were at very high risk of venous thromboembolism or arterial thromboembolism. They picked patients who had a D-dimer at or above 4 times the upper limit of normal, or patients who had a sepsis-induced coagulopathy score of 4 or more, which was essentially getting points for labs consistent with DIC or impending DIC. They excluded people who needed full dose anticoagulation for other reasons, people on dual antiplatelet therapy, or patients who bled over the past month, or patients with severe liver or kidney disease or with severe thrombocytopenia. Their outcome was venous thromboembolism or arterial thromboembolism. They also looked at bleeding. And what they found was 52 patients in the control group suffered from arterial or venous thromboembolism or death, whereas only 37 patients in the treatment arm. The treatment arm received 1 milligram per kilogram of Lovenox BID. There were 4 more bleeding episodes in the treatment arm than the control arm, all of which were patients in the ICU. And what they came out with was the number needed to treat to prevent a clot was 8 in terms of giving therapeutic anticoagulation. But this was a smaller study. When you look at a larger study, so this was a triad of three trials that were lumped together: the ATTACK, the Active 4A, and the REMAP CAP. Each with slightly different inclusion and exclusion criteria. They looked at hospitalized patients not in the ICU, stratified based on D-dimer. They excluded patients who were thought to be discharged in 72 hours, dual antiplatelet therapy, or high risk for bleeding. And they gave therapeutic heparin for 14 days or until discharge. They looked at death or organ support-free days. And what they found was that 76.6% of patients in the control arm met their primary endpoint of organ support-free days or survival, where 80.2% of patients in the treatment arm met that primary endpoint. This increased chance of survival or organ support-free days was retained amongst both high D-dimer or low D-dimer cohorts. And in terms of their secondary endpoints, they showed that patients who were hospitalized on oxygen but not in the ICU, who were given therapeutic anticoagulation, showed a lower risk of intubation, death, or arterial or venous thrombosis. And there were 11 more bleeding events in the treatment arm. When the same trial was conducted in patients who were critically ill, they actually found opposite data. They found that patients who were critically ill who received therapeutic anticoagulation who did not have a known clot were actually at higher risk for mortality. And this trial was stopped early because of futility and inferiority. Interesting, in this trial, there were fewer clots, there were fewer pulmonary emboli in patients who received therapeutic anticoagulation than those who received prophylactic anticoagulation. However, more patients died. The authors could only speculate as to what the cause was for that. It could potentially be due to alveolar hemorrhage, but it was only speculative. Based on those results and other trials as well, there amassed a set of data that shows that therapeutic anticoagulation in non-critically ill hospitalized patients probably improves mortality and definitely improves the risk of venous or arterial thromboembolism. And the benefit is likely more pronounced in patients with very elevated D-dimers. And that therapeutic anticoagulation in patients who are critically ill does not improve mortality over prophylactic anticoagulation and could actually be harmful. From there, from anticoagulation, we'll now move on to antiviral or immunomodulator therapy. And we'll be talking about dexamethasone, remdesivir, baricitinib, and tocilizumab. And rather going through this slide line by line, we're going to be talking about the trials themselves. First and foremost, the Act 1 trial. Now, the Act 1 trial was the landmark trial that looked at giving remdesivir to hospitalized patients. Now, this trial looked at hospitalized patients who were not receiving oxygen, who were receiving oxygen on low flow, or for patients who were on mechanical ventilation or ECMO. The outcome was time to recovery, defined as not hospitalized or hospitalized for a non-medical reason. And they found that patients who were given remdesivir versus placebo had a shorter time to recovery by 5 days. There was also a trend towards decreased mortality, but it did not reach statistical significance. And this benefit was most prevalent in patients receiving low flow oxygen. They did not find significant benefit in patients who were not hypoxic, and they did not find significant benefit in patients who are sick enough to warrant an ICU level of care. And there have been several other studies that also shows that remdesivir has been beneficial in patients who are hospitalized and on low flow oxygen. More recently, however, there was a trial called the Pine Tree trial that instead of looking at patients who were hospitalized, looked at patients who were at high risk for hospitalization. So the Pine Tree trial looked at patients who were 12 years old or older with at least one risk factor for severe disease, or patients who were 60 years old or older. Now, in terms of risk factors for severe disease, that was very liberally defined, including hypertension, diabetes, BMI at or above 30, as well as more significant risk factors such as active cancer or immune compromise. And notably, they excluded patients who were vaccinated. They gave remdesivir to these patients for 3 days, and their primary endpoint was whether or not these patients became hospitalized or passed away. And what they found was that patients who received remdesivir versus placebo were 80% less likely to become hospitalized. Now, from this trial, we have started giving remdesivir to patients who are high risk for hospitalization, as well as patients who are hospitalized and hypoxic. However, there is still no great data that shows that remdesivir works for patients who are hospitalized and not hypoxic, and there is no great data that shows that remdesivir works for patients who are sick enough to require ICU level of care. Now, a lot of our trials for remdesivir happened early in the pandemic, were randomized controlled trials before we had robust data sets for patients who were truly sick. Now, 2 years into the pandemic, we're able to look retrospectively. So there was recently a trial by Garibaldi and colleagues looking at almost 100,000 patients who were hospitalized with COVID over the past 2 years. And it looked at patients who received remdesivir and retrospectively looked at their outcomes. And what they found was similar to what was demonstrated in the Act 1 trial. Of these 97,000 patients, that the patients who had the most benefit were those who were on low flow oxygen, where there was not much benefit in patients who were on room air, and there was not much benefit on patients who were on high flow or non-invasive positive pressure ventilation. And compared to other trials, this study also showed a significant survival advantage rather than simply an advantage of hospitalization. This next slide shows a graph from, or a table from yet another retrospective meta-analysis that looked at patients who were hospitalized previously. This again shows a significant survival advantage in patients who received remdesivir, driven by cohorts on low flow oxygen. Now, I'm going to take a second to step away from the trials themselves and talk about clinical practice. We currently have an NIH level B2A recommendation to use remdesivir in hospitalized patients who are on low flow oxygen. However, in clinical practice, remdesivir is not universally used. And Dr. Auwaerter, I'm very interested in hearing your thoughts on the different trials of remdesivir, and some trials show remdesivir might not be as beneficial as others, and kind of the variability in clinical practice with this drug.
Yeah, thanks so much, Dr. Klimpl. I think you're right. Uh, in the US or North America, I think most centers are using remdesivir pretty much according to guidelines. But over the pandemic to date, there have been negative trials that have influenced people to say, well, perhaps the drug doesn't work that well. For example, the Solidarity trial, which was a very large early trial in many countries that it was not placebo controlled. It was a pragmatic trial with four different arms, and investigators could actually swap patients. So there are a lot of issues, and in fact, the remdesivir arm was had significant numbers of patients enrolled in Iran, which may not be, of course, the same level of medical care as the U.S. So and there have been other studies like the Discovery trial in Europe, which some point to a negative trial, but on subset analysis, much like the Act 1 trial you spoke of, people who are on a low flow oxygen and so on did seem to derive the similar benefits. So it's always been a puzzle that remdesivir, which is an antiviral, works because virologic data, when we look at does the amount of virus decrease when you check swabs or the oropharynx, for example, we don't see marked changes. But of course, that may not reflect what's happening in the lung, which is really one of the primary organs of interest. So I think many of us in the infectious diseases community do feel the drug has value for patients, and a study such as the Pine Tree data also speaks to how the drug is useful in a more traditional phase of illness, the first few days of infection before you're in the hospital, the so-called second or inflammatory phases in there. So that's sort of my take on it. And of course, many people in the hospital are just entering that inflammatory phase or there already. So it's a bit unclear exactly how and why it works, but my suspicion is it's working at some level within the lung to help facilitate clearance of virus and let the immune system sort of catch up and not overplay trying to clear massive amounts of virus.
Thank you so much for that clarification. It's very appreciative.
Well, I'm not sure it's a clarification or just still a discussion point because I think some do argue, and really outside of the U.S., the drug is used less in many countries, and of course, many trials that we're talking of, a subset of people are on remdesivir rather than a universal component of standard of care if it's a multinational trial. Well, I think this is my cue to go on to that so-called second phase of trial, a second phase, I'm sorry, of COVID, and that is that so-called hyperinflammatory response, where people become more ill, typically with COVID-19 pneumonia, but can also, of course, go on and have multi-organ system involvement. And as Dr. Klimpl mentioned, the pandemic has certainly changed from when many of these studies occurred. We're not dealing with the ancestral strain of virus, but we've gone through Alpha, Delta, and now Omicron. Substantial numbers of our patients now are immunized. So who are we seeing in the hospital? It's people with risk factors and unimmunized. It's people that don't respond well to the vaccine, solid organ transplants, people who might have B cell disorders iatrogenically or due to things like CLL in the patient case we spoke of, and don't respond well to the vaccine, so lack that critical neutralizing antibody response. And then other components of both the innate and then subsequently the uh, uh, adaptive immune system kick in and cause that increased cytokine drive that some people call a storm, but really is more of a sort of exuberant hyperinflammatory response. So a surprise, and I think many realize this is now a standard practice, was based on the UK trial performed by the National Health Service called Recovery, which has informed many of our decisions, which again was a kind of trial that did not collect copious data, but was meant to facilitate large numbers to try to get at basic endpoints such as mortality, discharge from the hospital, and need for mechanical ventilation. And this trial was rather surprising when you looked at the 6 milligram dose daily, that especially when mortality was so high early in the pandemic in the UK and even higher than we saw in the US, that 40% in people in the ICU improved, and even those on low flow oxygen also had benefit, which is why now it's been incorporated as a high level recommendation, at least with remdesivir for people in hospital on oxygen. Importantly, and this is true because in many places, I still see outpatients receiving dexamethasone, thinking it will benefit. And there's actually a trend towards poorer outcomes in this circumstance. And of course, we saw in countries such as India, where people had little access to other care, received dexamethasone early in their COVID illness and developed devastating fungal superinfections. One issue is dexamethasone was picked somewhat arbitrarily at 6 milligrams, and this was a relatively low dose compared to some of the other steroid trials in ARDS. And so people wondered if a higher dose worked any better. And so studies have looked at here a rather substantial number of patients, 1,000, who were hypoxemic, and they did a comparison and found that there was really a longer period. And of course, this confidence interval was not statistically significant, but basically it means we can stick to that 6 milligram dose, although you could certainly use equivalent corticosteroids if necessary that other trials have found benefit. Although remdesivir and dexamethasone have become rather fixed in place, there's two other drugs that I'd like to discuss more as classes that have really also become incorporated in our practices. And the first is the interleukin receptor blocker, tocilizumab, a monoclonal antibody, not to be confused with the ones directed against anti-spike protein used mostly in outpatients. But this one, of course, targets and prevents interleukin 6 action, which certainly is important for inflammatory responses. Unlike dexamethasone, which is a more broad impact, this one is quite targeted. And indeed, you might remember 2 years ago plus, the Chinese national guidelines had this as an option for care because people thought it might help the inflammatory responses. Although I don't have the data here today because of time, a number of trials that use this as a sole agent, meaning you only got tocilizumab if you were in that hyperinflammatory phase, failed, and it fell out of favor. But then the recovery trial and some other trials where it was combined with steroids, which had become standard of care, showed a particular aspect of it where when it was combined, there seemed to be benefit. So again, the recovery trial, which had over 4,000 patients, and by this point, most were on steroids, generally were on higher flow oxygen, but like all recovery trials, the patients got every intervention because they were hospitalized, and doesn't matter if they required oxygen or not. Now, patients generally in the UK were hitting the hospital much later than we usually see in the US, 9 to 10 days on average. And you did, in this trial, though, need to be with a somewhat suppressed oxygen nation level or require oxygen, and at least for entry criteria in this trial needed to have an elevated C-reactive protein, which I think is the biomarker we now all rely on to show significant inflammation in most patients and has been a predictor for poor outcomes. So this was a single dose of 8 milligrams per kilogram. And what you can see on this slide is that there was a benefit in reduced mortality, also a reduction in time or need for ventilation or dying again, and some improvement towards discharge. So it seemed this combination of dexamethasone and tocilizumab truly helped. And in a subgroup analysis, interestingly, whether patients had less than 7 days or more than 7 days, sort of as a breakpoint in that viral or hyperinflammatory phase, tocilizumab seemed to cause benefit. As you can see, if people got ill enough to be on the mechanical ventilator by the time they started, which was a much smaller group of patients, they didn't see a statistical benefit there. But importantly, look at the box that is in red. If you were on steroids, you benefited, but much like those early monotherapy trials in the 18% that were not on steroids, it didn't seem to help. So overall, there was definitely a trend favoring tocilizumab. And last summer, there was a time where tocilizumab during the Delta phase was in shortage. And a question came up whether again it was the right dose or not. Now, importantly, this trial was done during the monotherapy period, so it's a little hard to understand its significance. But rather than 8 milligrams per kilogram, a fixed dose of 400 of tocilizumab versus dexamethasone only was used. And although there was benefit in depression of C-reactive protein, at least in this trial, which albeit is small, didn't show any significance. So in a way, it's a bit like a non-inferiority trial. Perhaps there was no difference. There's certainly no worsening. So the authors here suggest that perhaps if tocilizumab is in shortage, that a lower dose might work. But again, this was not done in the era where it was combined with steroids. Now, tocilizumab has become one of the recommendations for patients that generally have had progressive COVID-19 infection. So someone that might be admitted on tocilizumab and admitted on remdesivir and dexamethasone, if you start moving up to high flow oxygen and so on, would get tocilizumab. Now, there is another class of drugs, such as this one, baricitinib, approved, for example, by the FDA for rheumatoid arthritis. This is a so-called JAK inhibitor. It inhibits JAK1, JAK2, which is a critical component for activating the so-called STAT pathway that drives cytokine responses, gamma interferon, and such. And so this helps modulate that. And an early trial done just after the remdesivir Act 1 trial was Act 2, which again used it as only monotherapy. There was no combination with steroids. And this did show some decreased time to recovery by 1 day, but it really never drove much adoption. But then the Cove Barrier study came up, a larger study that combined baricitinib. And at this point, again, most patients were receiving steroids, about 80%, because it became the standard of care. And the composite primary endpoint was either death or progression to high flow oxygen. And there was a trend, but not statistical significance. But intriguingly, all-cause mortality decreased. And this was a little unclear since it wasn't so straightforward that it was less time on ventilation and so on. But in subset analysis, those that didn't die or had the improvement in mortality mostly were driven by the people on that high flow oxygen, non-invasive mechanical ventilation, which is very similar to the same group that tocilizumab benefits. So this is really probably the sweet spot for this drug as well. And then here we're talking about the recovery trial again. Again, this trial enrolled everybody in the hospital. Most were on steroids. Some also received remdesivir. And most were, about 2/3 were receiving oxygen, but not everyone. So a little different trial. And again, there was a small subset that improved in terms of mortality that was statistically significant at 28 days, as well as a suggestion, again, absolute reduction is only 1%, but it was statistically significant given the size of the trial. So looking at all the JAK inhibitors out there, and some of the earliest ones were done without steroids, but most of the latter ones were done with, and include not only baricitinib, but other JAK inhibitors. And overall, again, there's a trend towards decreased mortality that, again, plays to the same as tocilizumab. Lastly, baricitinib in the Cove Barrier trial was looked at a critically ill cohort. And this was a small group of patients, a little over 100, that again got the standard dose of baricitinib, 4 milligrams orally per day for up to 2 weeks versus standard of care. And what they found in this group, again, was a substantial reduction in mortality at both 28 and 60 days. But interestingly, not really any other benefit in terms of mechanical ventilation and so on. So this may work on a variety of issues. Again, this is a small study, probably not enough to say baricitinib should be the treatment of choice in critically ill patients, but I think it remains an option. And in fact, many centers do use this or tocilizumab. I generally have not heard people using both regularly, but more one favored than the other. So I hope that was a summary of some of the key issues that are so important for care of hospitalized patient with COVID-19. I think Dr. Klimpl nicely outlined some of the evolving recommendations in anticoagulation in patients in order to prevent clots. So importantly, not people that have a clot, but for prevention. We talked about how remdesivir is the only FDA approved drug currently as a therapeutic for COVID 19, and how it's mainly still being mostly used for people on oxygen in the hospital. The pine tree data is interesting, and I think we might talk about that a little bit in our discussion, which did show a benefit for very early use, enhancing its role as an antiviral, keeping people out of the hospital. But especially during the sotrovimab shortage, during the Omicron surge, this became an alternative 3-day treatment for even patients in the hospital that fit the bill for not having significant symptoms, but were there for other reasons, such as a GI bleed. Lastly, the Garibaldi study looked at a massive amount of healthcare data, and at least by that analysis seemed to suggest there were benefits, certainly, in reducing mortality for those on low flow oxygen, which was hard to show in smaller prospective trials. Dexamethasone definitely has been incorporated into our algorithms for patients who are in that hyperinflammatory phase. And lastly, for those becoming more ill, I think tocilizumab or baricitinib are reasonable choices. Of course, we don't have head-to-head comparisons of any of these drugs, which makes it very hard to recommend one over the other, but we tend to look at the sheer amount of data that might support a positive aspect in clinical trials. So I hope that was a summary, and because this is a CME activity, I'm going to turn it over to Faith.
Again, thank you everybody for answering those questions here. As a reminder, as we move into the Q&A, to submit a question, please click that Q&A button to the left of your console. We will try to get to as many as time allows. Just as a note here, it's come to my attention that perhaps the slide deck is not loading the correct one for some people. My apologies for that. I'll double check that, and I will email the most contemporary deck to everybody at the conclusion of this webinar. So we're going to move now into the Q&A. The first question is, are monoclonal antibodies being used in hospitalized patients?
Well, maybe David, do you see it used at all in patients in hospital?
Rarely. I think that when we were dealing with the original surge and the Delta surge, more monoclonal antibodies were being used. However, as we more and more data came out showing that monoclonal antibodies were really most effective early on in illness, especially during the Omicron surge, we saw monoclonal antibodies used less and less in inpatients and more in a clinic setting.
Yeah, I think that's right. In fact, the emergency use authorizations from the FDA for the drugs such as more recently sotrovimab, which we had to pivot to during the Omicron surge because the earlier monoclonals didn't work well against the new variant. Uh, the EUAs say not to use it in patients requiring oxygen or a critical illness. So it's really only like the patient in our case where a monoclonal might be used with mild to moderate disease, where, gosh, if she hadn't ended up in the hospital because of a GI bleed, she'd be an outpatient and you might consider monoclonals. So you can use them in the hospital, but technically you're supposed to use them primarily in patients that fit the criteria for the EUA, or in fact, that's what you're supposed to do. It's interesting that a trial which we didn't talk about, again, a recovery trial, used very high dose of a monoclonal antibody, the product from Regeneron earlier, but used 4 grams in hospitalized patients. But the only one group that improved were those people that didn't have pre-existing antibodies to SARS-CoV-2. So a patient who might have CLL and so on might still benefit, but for the moment, we're rather limited there. If someone feels they need antibodies for hospitalized patients, and especially in the immunosuppressed population, that would be convalescent plasma, which has sort of fallen out of favor, but still as an EUA from the FDA, with the focus only for patients who are immunosuppressed and therefore really lack antibodies. And so that's really the drug we more often use in a limited number of patients in the hospital now.
Okay, fantastic. Dr. Klimpl, I'm going to hand this next question to you. This learner asks, is proning still being used? And if so, when should patients be put in prone position?
Great question. Now, the first thing that I will say about this is there's not a lot of great data behind proning. You will not be able to find randomized controlled trials or high quality data around proning because there's such a variable practice. Now, that said, proning is still being used, and there is still benefit, or there is thought to be benefit. And there is thought to be benefit in 2 specific clinical scenarios. The first is in patients who are between low flow and high flow oxygen. So we're trying to prevent someone needing to be on high flow or mechanical ventilation. And proning can theoretically temporize patients. We can get a little bit more time to maximize aerated alveoli. And the second population where proning is used is in patients who are undergoing mechanical ventilation, where mechanical ventilation is simply not sufficient in a conventional sense to ventilate your patients. Proning is not routinely used on all patients who are hypoxic. It is not routinely used on all patients who are on mechanical ventilation because it's traumatic to the patient. It causes traumatic dermatological findings. It causes tearing of the skin of the face, the skin of the chest. And it's very time intensive. You need multiple people in the patient's room to move them. So it's definitely still used, but in very specific scenarios.
Perfect, and thank you for that information. Dr. Auwaerter, maybe you can answer this one for us. Will there ever be a test which can effectively determine a patient's level of immunity against SARS-CoV-2?
Right. So you're really asking that question, which has been wanting for an answer during the pandemic, called, is there a defined correlative immunity, for example, with either infection-acquired immunity or vaccine-induced? And the WHO did come up with a standard of over 1,000 international units of anti-spike antibodies, which seem to correlate with people having neutralizing antibodies, which are really the key ones that are clearing the virus. So, if you have over a level of over 1,000, that probably correlates, although Omicron's thrown in a curve. because people that might have pre-existing antibodies, of course, um, Omicron was able to break through infection far more than Alpha or Delta. So it remains a moving target. I would say on a prevention basis, some of the patients most at risk do get prophylactic antibodies, so so-called pre-exposure prophylaxis with a product called Evusheld, which is silagivimab, tixagivimab, for anyone that's very immunosuppressed. And that does have activity against the Omicron variant. But again, it's everything is imperfect. And of course, we're still hunting for that exact level for confidence. But importantly, I would just say that if you're immunized and boosted, data available, regardless of your risk group, unless if you're immunosuppressed, your chances of hospitalization or death are really extraordinarily low. Um, and That's probably the best message we have at the moment.
Okay, and to wrap this up here, thank you everybody for. I'm very excited to have this much time to spend on Q&A. So we'll get one more in before we all say goodbye. Is there any value in using 10 days of remdesivir?
Well, I'll mention there have been and always early on an option to extend it to 10 days, but a study of 5 versus 10 days did not find a marked difference. Occasionally, we extend it to 10 days in people with profound immunosuppression, or a concept we didn't really talk about in this webinar is assessing cycle threshold. So, for example, in some hospitals, your laboratory might be amenable to providing you with a number from their platform that says how many cycles does it take for the PCR to generate a value. And for example, a level of 14 is far worse than 30, for example. And so in some of our more immunosuppressed patients that may have trouble clearing virus, we have extended or given an additional 5-day course, but it's really quite the exception.
Okay, fantastic. Well, I want to again thank our faculty for joining us today and giving us all these invaluable insights here for our learners. If you'd like to claim credit, please click that claim credit button. It'll appear when the webcast ends, and you should be able to see it now. But please be on the lookout for our 30-day survey. You'll get that in your email inbox. As always, your responses will help us develop further education. To our podcast listeners, please rate and review. It only takes a few seconds and really helps us grow our channel and our reach. And for those of us joining on YouTube, be sure to take the post test in the description to claim CME credit. Don't forget to like and subscribe to our channel to never miss our future videos. So thank you again, and we'll see you soon. Dr. Auwaerter, Dr. Klimpl, thanks so much.
Thank you.
Thanks.